Good afternoon, ladies and gentlemen. My name is Garrett C, and I'm extremely grateful for the opportunity and the very kind invitation from the organizers of the Asian Pacific Society for Cardiology to speak to you today at this excellent and interesting congress. And the topic of my talk is going to be risk stratification in Brugada syndrome. So the plan is to discuss three major issues. So first is to provide an overview on the risk stratification problem in Brugada syndrome. Secondly, I would like to review the clinical and electrocardiographic parameters important for risk stratification. And finally, I want to look at and demonstrate to you some of the multi-parametric risk scores developed by various groups. So as we all know, Brugada syndrome is a significant problem, especially in the Asian Pacific region. And really the most difficulty as clinicians that we encounter is what to do with the intermediate risk group patients. So we chose this disease to study because the disease prevalence is higher, and that also applies to Hong Kong, where all of our data came from. There's also very good linkage of electronic health record data in the public hospitals in the region. We have around 43 hospitals, and all of the records are linked and available to all of the clinicians in the system. So, for example, if a Brugada patient attends one hospital in the Hong Kong Island region and gets readmitted several months or several years later in the new territories, then the record is also available for viewing and linkage. So that's why we strongly believe that the data is very comprehensive in nature in terms of follow-up data, and there's very few missing data. So in terms of the impact, I think the way forward is to collaborate outside of medicine with colleagues from engineering and data science. So there's a lot of machine learning algorithms that can really help us to improve the risk prediction. So as you all know, the high-risk patients are quite relatively straightforward. So you give them an ICD if they've got very high-risk features, and for low-risk features, you just follow them up closely with some non-invasive tests, perhaps. But really, the problem poses when patients have a mixture of high-risk and low-risk features, and it's really the intermediate and slight low-risk group that provides a conundrum for clinicians. What risk is sufficient for us to give in an ICD to that patient. In terms of the indications, so for primary prevention, i.e. for patients who have never experienced arrhythmic events, initial risk stratification is based on the presence or absence of syncopal symptoms. Those are of cardiac or arrhythmic origin. So currently, if you've got prior cardiac syncope, the recommendation is a class 2A indication for ICD. For patients who have no cardiac syncope, but if they have a spontaneous type 1 Brugada pattern, then it's recommended to have the other investigations to look at any additional risk markers. So for example, electrocardiographic abnormalities, such as depolarization and repolarization defects. So genetics might want to look at, also family history. And there's also this decision point here with the consideration of program ventricular stimulation. So currently, if you've got negative PVS, and patients generally quite safe, so they only require close monitoring, whereas a positive PVS in the context of all of these risk markers, then it might be an indication for ICD that needs close discussion with the patient. So currently it's a class 2B indication only. So in terms of who should receive an ICD, there are also some regional differences in the guidelines and recommendations. So we have here on the left is the expert consensus statement from the HRS EHR and APHRS, and on the right-hand side, these are the guidelines from Japan. So they're broadly similar. So they, for example, the class 1 is when patients have had prior events. So these are secondary prevention. So class 2A, spontaneous type 1 and history of syncope on both sides, but on the Japanese guidelines, they've also included family history of sudden death and also inducible BF on programmed ventricular stimulation. And so in terms of the various risk markers and the domains, I've categorized them into different clinical and ECG and genetic categories. So symptoms-wise, a syncope with the type 1 pattern is associated with a fourfold increase arrhythmic risk, but we should be careful because not all syncope is equal. Neurally mediated syncope is more benign than cardiac syncope, so we do need very good clinical history from the patient. We need to look at the events leading to the syncope, any prodromal symptoms, any precipitators. So we need the patient's own descriptions and also the witness accounts, any bystander witnesses that can tell us the events, the time frame, the duration, what the patients were doing, because some of the recollections might be biased and not so accurate, especially if the patient has had something traumatic like a total syncope. So there is a possible role for intense rhythm monitoring with implantable loop recorders for patients that have not got very accurate accounts, or if there is any uncertainties as to the clinical scenario. Asymptomatic patients are problematic. Previously, we thought that they were low risk patients, but there are some studies that have shown that the 10-year period there is a very significant 7% risk. So this is high enough for me personally. If I'm in the 7%, I would want an ICD. But of course, the risk benefit needs to be discussed with each patient individually. So as the meta-analysis showed, so this included around 1,300 patients from 10 studies with around 5 years of follow-up. You can see that if it's arrhythmic origin, it's a very, very high event risk. If it's undefined, it's not no risk, so it's relatively comparable. It's a bit lower than the suspected arrhythmic group. So these patients are problematic in terms of arrhythmic events in the future. And even those that are deemed to be of non-arrhythmic origin, they're still at some risk, although they're low-risk patients. The ECG patterns, spontaneous type 1 pattern is very important risk marker compared to drug-induced pattern, but the sensitivity to pick up the spontaneous pattern increases when you put the ECG leads higher up into intercostal spaces. So spontaneous type 1 pattern and cardiac syncope is high risk, but what about spontaneous type 1 pattern and often asymptomatic? Well, study recently showed it's relatively low risk. And you also want to ask the other question is, if you've got only a drug-induced pattern, is it always low risk? And really the answer is no. So as this study tells us, for those patients that presented with aborted sudden cardiac arrest, so these are patients with the first presentation being arrhythmias or sudden cardiac death, a significant portion of them had only a drug-induced type 1 pattern. So clearly drug-induced type 1 pattern is not always low risk. So in terms of programmed ventricular stimulation, that has led to significant and heated debate across the board. So the Brugada group has been a very strong proponent of programmed ventricular stimulation, whereas other groups have casted doubt and have raised issues with respect to the precise stimulation protocol, patient inclusion criteria. So we do need to be cautious when we're interpreting findings from PBS studies, so we need to closely look at whether there's good standardization across the PBS protocol and also the patient selection. So as we now come to be aware, the intermediate risk patients are the most problematic. Are we going to put in ICD or are we not going to put in ICD? So invariably, we're going to make some incorrect decisions. So we try to improve upon the risk stratification by developing risk scores. So one of the scores, the Shanghai scores, originally designed for diagnosing Brugada syndrome, but recently has been tested for its ability to predict prognosis. And over the past years, various groups have developed multi-parametric risk scores, but not many have been externally validated. So this is a score that's been developed by Professor Lambiase's group from the UK, where they incorporated 4 key characteristics. So the presence of type 1 Brugada pattern in the peripheral leads, syncope of arrhythmic origin, early repolarization pattern in the peripheral leads, and also spontaneous type 1 Brugada pattern. And as they demonstrated, as the risk points increases, the 5-year predicted risk of arrhythmic events or sudden death events increases. But really the problem is, what do you do with this low risk score patients? Do they want an ICD or do they need an ICD? So from us, we've also made some contributions, and we demonstrated that if you do multiple testing of an ECG, and you look at the visit-to-visit variability in the ECG markers, then they can also stratify high risk from low risk patients. And we also found that there are differences in rhythmic risk between pediatric and young versus adult presenters. So at the very least, we need subgroup specific scores or age being incorporated in the risk model. And our team also found that if we look at the automated ECGs parameters, so these are the measurements that are made automatically by the machine, the various amplitudes and waveforms, and if we apply the machine learning methodologies to these data sets, then they are much more accurate in terms of risk stratification. So the more data we put in, generally, the better risk model or risk calculation we're going to obtain. So I won't dwell on this later, but with the only point that if we apply random survival for us and non-negative matrix factorizations, these are machine learning methodologies that can extract latent features between risk variables, then they're generally much more accurate than traditional Cox regression-based models. So in terms of the global context, I think really the way forward is to incorporate a multi-modality domain. So we need to look at not only ECG patterns, but also the age of diagnosis. And also recent work has demonstrated that the location of the SCN variants are important. So this is a paper that we co-authored with Professor Dan Hu's group in Wuhan in the US, and we found that if you incorporate family history, age, ethnicity, and the TPT and interval, it's relatively accurate for risk stratification. And really the future, we believe, is if you look at the location of the mutations, it might be more accurate for risk prediction. And it's not surprising because various mutations have very different effects on the ion channel function. So if, for example, if you have a poor mutation or mutation that affects predominantly the ion channel pore, then you're going to significantly impair the activation or inactivation characteristics of the voltage-gated sodium channel, and really affects the conduction and depolarization processes. And that if you have a mutation that's perhaps more distant from the pore region, then the effects might be less. And of course, that wouldn't apply if the mutations at the 5' or the 3' regions. So if you affect the splicing region, then you might have a more dysfunctional effect. This is a summary of the different risk scores. So you can see there is great heterogeneity in the variables that are incorporated in these risk scores. Across the board, most studies have incorporated syncope. Most studies have incorporated spontaneous type 1 patterns. So these are really the agreed features that are high risk already. But really, we really do need to look at additional details, whether it's other types of arrhythmias, for example, atrial fibrillation or sinus node dysfunction. PVS, there is a good case for incorporating that, and of course various electrocardiographic findings, whether it's depolarization, repolarization markers, or its other aspects. So as we said earlier, really we do want a multimodality approach, incorporating not only the clinical and ECG criteria, but also the genetics, which are clear drivers, at least in a portion of the cases of the electrophysiological substrate. So before I finish, I just want to invite you all to join this international Brugada ECG Indices registry that we are leading. So we aim to incorporate cases from previously unrepresented regions. So we have already collected around 1,500 cases globally from 18 countries. We've got cases from South America now. Also, we've got cases from Thailand. We've got cases from various parts of Asia and also Europe, as well as Russia. So really, we want to build this study because we can validate the scores that have been developed by other groups, but also we want to develop our own score with the machine learning driven methodology. So there is no minimum case requirement. So if you only have several cases, we still want to include you in the study and of course in the manuscript that arises from it. And if you're interested and you've got some Brugada cases, please please do drop me an email here. So in conclusion, then, ladies and gentlemen, we believe a multi-parametric approach is the way forward for accurate risk stratification of Brugada syndrome. The most difficulty for clinicians, so for us, is really, what do we do with these low or intermediate risk patients? Because the event is such a debilitating, such a significant event, even 1 to 2% risk might be too high for our patients. And there are various scores that are available for risk stratification, but not many have been externally validated. And this is why I do encourage you to join our Brugada study so that we can test various scores that have already been published in the literature. And we also want to test the hypothesis that the machine learning driven approaches are better than traditional Cox regression based models. So thank you very much for your attention. Look forward to discussing with you shortly.